Wonderful. All right. Well, I'd like to officially welcome you all to the 2024 National Fertility Meeting, the Australasian Institute for Restorative Reproductive Medicine. We few, we marry few. It's been 10 years since we first began meeting here in Melbourne. At that time, they were really bioethics gatherings with discussions about interesting medical cases and trying to get a grip on some of the medical principles we could apply to help people in difficult situations. As many of you would know, he had prepared the Jewish people over many years. He had had his soldiers circumcised. They were all ready to go. And as he was looking towards Jericho, a man in battle armor with a sword drawn appeared to him. And he said to him, "Are you with our adversaries or with us?" And the angel said, "No, neither." And he said, I'm with the army of the Lord, and I'm ready. So today we're gathering. We're a small core group. There's many others that would like to have been here but can't, unfortunately. And as I said, there's many with us in spirit and prayer. There'll be many others that from the meeting today will have the opportunity to listen and contribute, because the women, the couples around us, they do need better. And I know that we can all continue to help them and do better. So please let us make the most of the presentations today and the discussions that'll follow. Let's use it as a building block towards bigger and better things moving forward, and as a time for personal reflection and rebuilding. Before we move on to the public forum, I'd like to thank the conference committee that's put in a lot of work over the last year to make this happen. Particularly thanks to Dr. Mary Tonti Filippini, who was our chair until recently, for giving us the confidence to keep moving with this, and for finding our venue, which is really lovely. To Lauren Harkness from Rise Events, who's came on board some weeks ago to help us cover across all the little details that are very hard to do without someone who's dedicated. So thank you, Lauren. I'd now like to introduce Dr. Joseph Turner. Joe is a GP based in Armidale. He's one of our former board members and a real leader in this space in Australia, and he's going to lead our public forum today. Thank you.
Thank you, Gabe. Thank you for that welcome. It's a pleasure and a privilege to be back here after a bit of a hiatus in this sort of gathering. So welcome all from me as well. So I do have the pleasure of introducing the members of our public forum, and I'd like it if they could all come up all here together, and I'll give you a little bit of background about each of them. And we'll move through a journey of, restorative reproductive medicine from the couple's perspective, as well as from the fertility awareness practitioner and the medical perspective. So we're very interested to hear your story, Jess and Paul, and we'd like you to tell us about how you started your journey together as a family, as a couple, and an overview of your experience leading up to your pregnancy, but also how you were engaged with the fertility awareness practitioners and how you then moved on towards medical and surgical assistance in your journey to being pregnant. Thank you, Jess and Paul.
Thank you, Joe. So we start from the beginning, I suppose. It started with, at the age of 16, I got my first period. And I remember the pain. There was no real pain at the start. It seemed to increase as I got older. I remember being in year 12, doing my HSC exams and having terrible cramping and putting an exemption for that. My mum never had any trouble. She had seven children and didn't have any pain. My two sisters had a little bit of cramping, but nothing like I experienced. So the pain itself, as the years went on, it was very severe cramping, tiredness, and I was very emotional. I couldn't really function properly for 2 to 3 days of the month when my period fell, and I felt like I was really hit by a truck. There were times when the cramping was so bad, I felt like self-harming, like cutting myself in other places just to take the pain away from my uterus. There was lots of questioning that I had, like, was this normal or was it all just in my head? I even had a friend who once said to me, do you think maybe that you've just got a low pain threshold? Which, yeah, I did. So doctor visits, over many years, I visited many GPs and other health professionals such as naturopaths and acupuncturist specialists, but no one ever suggested that it could be endometriosis. I had multiple ultrasounds, but they showed nothing. In the end, the doctors just said, well, the best thing for you could do for your pain is to go on the pill. So at the start, the doctor advised me just to take the pill consecutively as long as I could without having a period. So I just took it for months and months until a period would finally break through. And so I started the pill about age 19 and continued for 6 consecutive years until I took myself off it due to skin pigmentation. I was also offered antidepressants by one doctor when I spoke about the self-harming and just the emotional state, during the time of my period. But luckily, I declined these. It was my mum's friend, Anne-Marie, who she had suffered from endometriosis, and she'd seen me many times during my period and said, look, I think you've got endometriosis. So she advised me to go and find a good gynecologist and ask for a laparoscopy. But due to living and working overseas for a couple of years and then teaching up in the Kimberley for a year and a half, it wasn't until several years later that I actually took her advice and did that. So when I finally settled in Warragul in 2009, I went and found a local gynecologist, and she operated and did the first laparoscopy. And I remember her saying to me, it's endometriosis and you're riddled with it. So it was good to know it wasn't all my head. She advised me then the best thing to do was go back on the pill. So I went back on the pill. She also said that if you wanted to have kids, that, I should do it sooner rather than later. But it was a little bit of a problem. Hadn't found Mr. Right yet. In 2011, I had a second laparoscopy, again at Warragul Hospital. This time it was an endometriosis specialist, who I never got to meet actually, but he came down from Melbourne and operated. In the follow-up appointment, the gynecologist said, yep, best thing you can do, stay on the pill. So continued on the pill. A few years later, the pain, continued. It got really bad in my left ovary, and so I went and saw another local gynecologist. He just said when the pain was too much, they'd remove my ovary, and that later down the track, I'd have to look at a hysterectomy. So I thought, oh, well, yeah, thanks, no thanks. So I decided then and there really that, clearly no one could actually help me with the pain. It was just something that I had to put up with. So 2000, and I thought, I really probably shouldn't be on the pill because of my family history, both sides riddled with breast cancer. And my mum actually had breast cancer in her early 40s. So I took myself off the pill. That, again, was another stint of about 6 years. So then finally I meet Paul in 2015. And early on I said to him, look, I don't know if we can have kids because of my endometriosis.
And yeah, I really appreciated Jess's honesty as well. And we just thought we'd leave it in God's hands. So when we got engaged, we did a pre-marriage course with Dr. Lucia Manane. So she presented. That was really beneficial for us.
And yeah, it was great. And then Paul soon learnt that every month he should block out 3 days in the calendar that we wouldn't be doing anything.
That's right. So there was no live sport, live soccer like that photo or other things. And yeah, it was very challenging at times, but Jess's profession too, I think, as a primary teacher, she was very emotionally and physically invested in the job. And from 2017 to 2021, she was teaching preps. So you can imagine how challenging that can be at times. And there was a few occasions she went into work where I felt she wasn't well enough. And yeah, I think that was probably to the detriment of her health and shows her dedication too.
So in December 2016, we were married and we started trying to conceive straight away.
It was clear to me that Jess's, or I should say our fertility was secondary to improving Jess's quality of life. So as much as we wanted to have kids and conceive, it was really obvious that it was having a big impact on Jess's life.
So after about 6 months, nothing had happened, no baby. So because of my endometriosis and also because of our age, I was 36 at the time and Paul was 38. We thought we'd be proactive and find a bit of extra help. So we found a gynaecologist and fertility specialist at private hospital. And early on in she actually I had my tubes flushed to check to see that they weren't blocked due to the endometriosis. She was very hesitant to operate, this doctor.
And yeah, it was clear there was a big push for IVF. For us, this was never an option. And probably a little bit disturbingly, just after that photo was taken before Jess went under, it was even mentioned again. So that probably didn't give us a lot of confidence in many ways, I think.
So in March 2018, I had my third laparoscopy, but unfortunately, we didn't have any luck conceiving after that, and there wasn't really any decrease to my pain. So we actually did look at even adoption and permanent care, but with the adoption, we were basically told because of our age that we'd never be chosen as adoption parents, and permanent care was just really quite impossible. So we knew Patsy through our parish, and we knew Patsy that taught the Billings method. So we thought that would be beneficial for us.
Parents use this method, and earlier I taught in a girls' Catholic school, and it was presented there, but it was great to go into a lot more detail with Patsy.
So in March 2017, we started to learn the Billings method, thanks to Patsy, and it made a lot of sense, and it was very clear, and I'd wondered why I hadn't been taught it as a young lady. Thought it was very important. The routine of it was probably the biggest thing, just getting into routine of charting every day and just thinking about what you needed to chart.
Thank you for sharing, Jess and Paul, and we'll continue with your story shortly. So what they've highlighted, and it's what Dr. Gabe James highlighted as well, is that there are different approaches to the way we look at fertility in our current context. And the basis of AIRRM, of this way of doing things, is restorative reproductive medicine, which is working with the fertility potential of the body and working cooperatively with the body. So there are a couple of different methods of looking at the basics of this, the fertility awareness methods, and Patsy, well experienced in one of the methods, the Billings ovulation method. We'd like to ask Patsy, can you explain to us a little bit about the Billings ovulation method?
The Billings ovulation method is a natural method of family planning. It enables a woman to recognise her potential fertility. It also allows her to recognise her infertility after ovulation and in the pre-ovulatory phase of her menstruation cycle. During the time of infertility, in the pre-ovulatory phase of the cycle, the level of estrogens is low, and this hormonal pattern is reflected by a lack of cervical mucus, or very little. We refer to this pattern as the basic infertile pattern. Any variation in the length of the cycle occurs in this pre-ovulatory. The basic infertile position, you can see by the chart, this is a chart of a normal cycle. The first couple of days are red. The woman has recorded this each evening. The red is for the bleeding, The next couple of days in green are what we call the basic infertile pattern. There is no discharge or very little. But during this period of time on the green 4 days there, they will be exactly the same. As soon as this pattern changes, we have fertility building. It's a constantly changing mucus at the vulva, which the woman will record. You can see there there's comments that she would make to show that it's a bit different every day. It could be sticky, it could be stretchy, it could have strings, it could be clear like egg white. The woman becomes aware of a feeling of slipperiness as she moves around. The last day of slipperiness, as she's walking, is the peak day of fertility. This change, it is immediately followed by a day of dryness. I think you can see up there where the point is, she would not mark that day as her peak until she has the next day, which you can see has gone dry. It's green and it's dry. She's totally different mucus altogether. There might be a little bit more fertility, there might be a little bit more mucus, but for those 3 days, conception is possible. The peak day is the day of the height of fertility. After the 30 days, the egg is dead and she will be able to have her menstruation will come within 11 to 16 days after. If a couple want to avoid pregnancy, the woman will make the same observations and record each evening. Any mucus interruption during the basic infertile pattern, we go back to the green those days straight after the bleeding. Any interruption there, be it bleeding or mucus, she will have to abstain for 3 days to ensure or to check whether the basic infertile pattern is going to return or whether she's going to move into her fertility, the changing mucus. She will count 3 days following the peak day because she'll do the same thing. She'll be looking for the mucus, she'll see how it changes, she'll have the slippery feeling, and then she can recognise that she's reached her peak, and so she can count 3 days before she has any marital relations. To ensure avoidance of pregnancy, there are 4 basic rules. The first one is to avoid intercourse on days of heavy bleeding during menstruation. The second rule is alternate evenings are available for intercourse when these days have been recognised as infertile. The third rule is avoid intercourse on any day of mucus or bleeding which interrupts the basic infertile pattern. Allow 3 days of the basic infertile pattern before you return to married relations. The fourth rule is ensure that there is absolutely no genital contact until the beginning of the 4th day following the peak of the mucus. That's just the nuts and bolts. There's obviously a lot of variations that go on, and so there are plenty of people, teachers, who would be able to help anyone who needed any further advice. Thank you.
And we agree, Patsy, that the more people, women, society know about this earlier on, the better it is. We will approach that later on in the conference. Thank you. So, Patsy, what did you find from Jess's chart, please?
Have a look at them. If you've had a chance to really take in that first normal cycle, you can see that they're all just normal cycles, every one of them. She was bleeding for a couple of days. The first one, the very first top one, that was when we were first getting to know it and we weren't all that good at recording things. But if you look again, you'll see that she bleeds, she has some dry days, she has a bit of mucus, then she has a changing, developing pattern all the way where she's written all bits and pieces about what it felt like by the end of the day. And she's able to establish a peak day, and she's followed by a long period of infertility. Now, to me, I'm not a doctor. I don't know very much about all of these things. To me, she was just having normal cycles, and I couldn't understand why it wasn't working. So that was when I referred her to Dr. Mary Walsh. I knew that Mary had an infertility clinic, and of course they're two busy teachers and they think that they haven't got time to do this and they haven't got time to do that, but they did find time to go down and speak with Mary, and she was able to take them on the journey. Thank you.
So, Jess, you've already been through so much already, and now you come to this point where you work out that your cycles are actually looking all right and you need further investigation. Can you tell us a little bit more about what happened with Dr. Mary Walsh?
So in March 2018, I think we started to see Dr. Mary Walsh, and we were very impressed with Dr. Mary from day one. She was just so caring and thorough, and straight on to checking things with blood tests and my overall health.
We didn't really find the process difficult, but you definitely need to take some ownership in the process, I think, and be very proactive. And we found that really good, didn't we? It was very good as the husband in the relationship, I think, to learn more as well. So
with the charting, obviously, was important. Dr. Mary Walsh put me on lots of different supplements. So the charting, I would then have to look at my chart, and then once I thought I'd ovulated, I'd have a blood test, and I'd text Dr. Mary and she'd say, start the progesterone. So we'd have the progesterone for 10 days and then have a pregnancy test, which always seemed to come back negative, which was hard. But so yes, it was good. We were both on board. Later on, Dr. Mary actually prescribed naltrexone to help with the pain, and whilst it took a few months to kick in, it did seem to help with the pain, and it also really helped with that total exhaustion that I felt every month when my period arrived. It was actually late in 2020, though. We said to Dr. Mary, we said, "Oh, thank you, Mary, for everything, but we're done." We thought, we were at peace, and we thought maybe it wasn't God's plan for us to have children. But she said no. And yes, it was then that she had another card up her sleeve in Dr. Brendan Miller.
So, Dr. Walsh, when you saw Jess and Paul come to you, treating them as individuals, treating them as a couple, can you describe to us your approach to managing this situation, please?
Thanks, Joe. It's been a real joy to journey with Jess and Paul through this, so it's lovely to be here today to tell the story. So in restorative reproductive medicine, as you know, the aim is to restore health, and so restore hope, and then aim for a natural conception. So the pathways that couples will come to a restorative reproductive medicine doctor would be either through a fertility awareness teacher who perhaps recognises abnormalities in the chart, or just that pregnancy hasn't happened in 3 to 6 months, and they'll refer them to a doctor. Otherwise, they might come to a doctor first, and who will then ensure that they learn a fertility awareness method, and then in conjunction with the charting and investigations, formulate a treatment plan. The outcome, hopefully, is that the health is restored, the conditions that we have discovered that are contributing to the infertility are fixed, and hopefully pregnancy will happen. So why is the fertility awareness chart so important? Well, we do know that a lot of couples, this study was done in 2012, but only 13% of women who were actually looking for assistance with their fertility when they were surveyed found over 13% of them knew anything about identifying with accuracy their fertile time. So it is so important, and it's so under talked about, as we all know, is a study of conception rates among couples with normal fertility using a fertility awareness method. So we know that 98% will conceive roughly within 6 months. The standard definition of infertility, which is of 12 months, doesn't apply to fertility-aware couples with normal fertility. So they need early referral rather than waiting for the 12 months. So what does an AIRRM infertility assessment look like? Well, of course, we look at the factors concerning the female, factors concerning the male, make sure that charting is done and looked at by the doctor, thinking about non-surgical medical treatments to improve and restore function, and then, of course, looking for further investigations and surgical management if necessary. So For the female infertility assessment, there'll be a thorough medical and family history looking for clues like diabetes, previous health issues, previous surgeries that might have been done. There'll be a physical examination which has to include cervical and vaginal swabs looking for infection that can inhibit fertility, plus or minus a cervical screening test or a pap test as necessary. It's essential that the fertility charting record is looked at, so that'll either be on paper or these days mostly on an app. Couples will come in often with apps that they're using, and you'll see that they're not actually charting any fertility, they're just going by what the app is telling them about counting days and expecting a particular time to be fertile. Investigations, initially a basic pre-pregnancy blood test looking for general health conditions, making sure they're immune to chickenpox and German measles, but checking iron levels, vitamin D, the sort of thyroid function, basic tests that are done, blood group. And then we do a thing called a basic hormonal profile, which we'll come back to in a short time, but that's a general overview of the hormonal profile of the woman. Thinking about inflammatory or immunological factors that might come into it, genetic studies if that's necessary, and a pelvic ultrasound just to assess, the overall state of the uterus, whether there could be fibroids or polyps or growths, looking at the ovaries for cysts or evidence perhaps of endometriosis. Looking at the basic hormonal profile, this is done early in the cycle, when day 3 to 5 of the cycle, or if the woman has no periods, it's done at any time. So as you can see, they're tests looking at the general hypothalamic pituitary ovarian axis. So looking at the basic hormonal patterns that we can pick up and look to see whether there are abnormalities that need to be investigated further. So it covers prolactin, cortisol, the androgen hormones, and FSH and LH. We also, vitamin D, we know is a hormonal picture, so we make sure that that's looked at. And then very importantly, we do a glucose tolerance test with insulin curve, looking for insulin resistance, which we find very often as a hidden factor in for couples who have infertility problems. The antimalarial hormone is looking for the follicle count from the ovary. And if there are abnormalities detected in that basic hormonal profile, then we'll look for functional tests to follow up and manage those. And using the FAM chart. So why is the FAM chart so important? For several reasons. We check for abnormalities, so abnormal bleeding, abnormal patterns of mucus. We can look at and think, well, we know what might be contributing to those. But looking also for luteal phase and periovulatory hormonal testing. We just look at the next slide. I don't know whether you can point to that chart there, Paul. Yes, so you can see the as you've shown from Patsy's definition, that's the Billings chart at the bottom, but look at the line above that is the curve of the estrogen rising around the time of fertility. It's a very big rise in estrogen from, about maybe 100, 200 up to 1,000 or more, and then a drop, and then starting to rise in the yellow line there is the progesterone. And then you look at the curve after ovulation, you can see the progesterone and estrogen rising for a week. If pregnancy happens, those hormone levels will increase, but if there's no pregnancy, they will drop and the period will come. So we can actually chart or track for couples who are unsure of their fertile time, the estrogen rise, and help them to predict when ovulation will happen. So we look for that for some couples, and then we look also for the estrogen and progesterone curve in the luteal phase, which is the phase after ovulation. And we can tell by looking at those levels if it's a healthy ovulation or not. And if it's not a healthy ovulation, we can help supplement those levels with progesterone. In Jess's case, getting back to the story, 2018, Jess's initial pathology showed a bit of low iron and a bit of lowish vitamin D and lowish zinc levels. So she was put on supplements for those. In 2018, this was interesting, her basic hormonal profile was quite normal. So she didn't really need any intervention there. But when she was a little older, a couple of years later, redoing the basic hormonal profile, she had gone into that sort of early perimenopausal time with having low androgens, low testosterone levels, low DHEA, and lowish estrogen. You can just see the changes starting to happen. Her first luteal phase monitoring in 2018 did show some deficiency in her progesterone levels. The initial rise was good, but her progesterone levels dropped very markedly, very quickly. So she was placed on vaginal supplemental progesterone, as Jess has already said. And as we know, as we talked about in 2018, her cycles were really looking okay, regular cycles, recognised really good mucus changes and fertile time. But by 2020, the changes were less obvious. She was getting a bit older. Her ovaries, the cervix was getting a little bit older as well. So things had changed over a couple of years. So in terms of management, so initially she was make sure a lot of couples who come in, I find, actually don't take an antenatal. They don't seem to be aware of the need for folic acid. So it's really important to make sure that they're taking an antenatal. She had iron supplements, vitamin D and zinc, the luteal phase, vaginal progesterone, and the healthy lifestyle was always talked about, of course. So you make sure that eating well and exercising well and trying to maintain a balance between the stress of all these investigations and a healthy life. We knew that Jess had endometriosis and with very painful periods, as she's mentioned, and eventually, as she has said, we tried low-dose naltrexone, which really helped significantly. In 2020, because of those abnormalities I talked about, we added further supplements, DHEA, CoQ10 and vitamin B6, which is useful for improving the mucus pattern. So after we've done all of those blood tests and the basic pelvic ultrasound, the AIRRM approach is then to consider further tests. So it could be tubal dye studies or just to test the tubal patency, the opening of the tubes. Think about ovulation induction, think about laparoscopy and hysteroscopy, and consider an early laparoscopy. It's really true that sometimes endometriosis can be discovered and that's the only symptom that people have had is not getting pregnant. They won't have necessarily the pain or the funny bleeding or the abnormal patterns, but they're not getting pregnant. So laparoscopy so often discovers endometriosis, and that needs to be addressed. So for Jess, we talked about the referral for a second opinion to Dr. Miller to look at ovulation induction options and laparoscopy again. Okay, so the next part of the AIRRM approach is the male assessment. So again, a thorough medical history, family history. It's important that fertility depends on the couple. You know, the healthier the woman is, the healthier the man is, the healthier their fertility will be and the healthier the pregnancy will be ultimately. Physical examination, again, the basic profile, general health checks and the basic hormonal profile, especially looking at testosterone levels and the pituitary hormones, looking for infections if necessary, plus or minus a prostate-specific antigen, a PSA if necessary, genetic studies to think about. Seminal fluid analysis, most important naturally, and the way in restorative reproductive medicine we approach that is with a male factor pack, which is a condom collecting device, which allows the couple to collect the seminal fluid during an active intercourse, and then post haste they have to get it to the laboratory, but they do manage, and I think it gives a better option for analysing the seminal fluid very clearly, and it's culturally acceptable and religiously acceptable as well. Looking again at vitamin D, very important for male fertility, and glucose tolerance test with insulin levels. And if abnormalities are found in the seminal fluid analysis, looking at a testicular ultrasound. Okay, so for Paul, he was very healthy, which was really good. His basic pathology tests were really good. And and that's really great. If you don't have problems on both sides, you know, you can breathe a bit of sigh of relief. So it was lovely that Paul was healthy and able to support Jess in her journey. So reassurance for a healthy person will continue a healthy lifestyle, multivitamin supplements, which is just something that they can take, which can contribute as well to health. So in general, the restorative reproductive medicine management approach is restore the deficiencies that you find, so iron, vitamins, minerals, other supplements, treat any abnormalities hormonally that you might find, so they need to be treated, treat infections, look at surgery as a treatment option, a healthy lifestyle with adequate exercise, good nutrition, healthy weight, make sure you discuss smoking, alcohol and drugs. The psychological factors are very important. It's a very stressful journey, a lot of grief and uncertainty and depression can creep in. So it's vital that that is addressed if necessary. And allied health referrals, of course, are really important in all of those regards. So psychologists, dietitians, exercise physiologists, physiotherapists can all help along the way with the team approach, and specialist medical referrals as indicated. So whether it be specialist gynecologists, urologists for the man, or an endocrinologist. And just looking again, as Patsy has also alluded to, the reason that we believe in all of this is because it works. So if you look at these 3 studies from different times, you'll see on average the cumulative pregnancy rate around 24 months is around 60% with restorative reproductive medicine approaches, and the live birth rate on average is around about 60% as well. So it's good management, it's good medicine, it's good treatment. And restorative again, just flicking through these, you can see it can be difficult to compare it to ART, but we know that in general the pregnancy rate does exceed conventional fertility treatments, but it does take longer probably for the couples who go through the restorative approach. And I think that's the benefit that we have in restorative reproductive medicine. We can actually spend longer with couples. In the fertility IVF world, I think couples, they're 6 cycles, maybe 12 cycles, and then that's, doesn't work. No, you'll never get pregnant. But I think we have the privilege of being able to journey longer with couples, which helps. Other applications of restorative reproductive medicine you can see there. So just click through these, I think, too. Endometriosis, pelvic adhesive disease can be treated with surgery, threatened miscarriage, preterm birth prevention, postnatal depression. Progesterone is very useful for those. Recurrent miscarriage, dysfunctional uterine bleeding, premenstrual syndrome, we can address those as well. Polycystic ovarian disease, and the others. Yeah, so male infertility can also be addressed through restorative reproductive approach. And then the next slide. And if you're all asleep, then now you can wake up again.
So it's a comprehensive approach. Thank you, Dr. Walsh. And I'd like to point out, maybe for the people who are joining us online, that when Dr. Walsh was explaining the hormonal changes during the woman's menstrual cycle, it was actually Paul who was pointing out what was happening with those changes. So it was lovely to see how involved he was in the process as well. Jess, can you tell us, you're looking down the barrel of another surgical consultation. How did that make you feel?
Well, at the start, actually, initially when Dr. Brendan said he wanted to operate, I was very surprised because the last surgery I had, the surgeon said that would be the last surgery that they'd give me for my endometriosis. So I was quite shocked when he said that he would like to operate. But when he explained to us that number one, well, the endometriosis grows back. So number one, it could help with my pain, and number two, we could check to see if it was still possible for us to conceive. We were very excited.
It was great to get away from Victoria for the winter, although I don't think Toowoomba was any warmer. But we did have a bit of long service leave prior to that, which was lovely. So yes, we actually gained a lot of hope in our follow-up appointment a few days after the surgery that conceiving was a real possibility. So that was wonderful. Unfortunately, Jess suffered a bit of a hiccup along the way. So 16 days post-surgery, we just arrived back in Victoria after a big 24-hour journey through Queensland and New South Wales because of COVID restrictions. But we stayed in Queensland the 14 days to minimise the risk of a rupture. But upon arriving home the second night, Jess had internal bleeding and was subsequently rushed to the Monash in Dandenong, where close to a litre of blood was removed. And yeah, couldn't thank Dr. Brendan enough just for his care and concern, and also his communication. He was always available, and just checked in regularly. So we were so impressed. Thank you.
Well, it took me months and months to recover after those 2 surgeries. And when I finally did get back to work, we actually lost our jobs due to the mandate. But approximately 6 months after that amazing surgery with Dr. Brendan Miller, surprise, we conceived. So thanks to these wonderful people here, maybe the decreased stress of our jobs, or no longer having our jobs, and the thousands of prayers, along came
Luke James Carroll, 9 months later, born at the...
Thank you, and a wonderful ending to that story. We'd like to now hear from Dr. Miller and listen more about the surgical approach. I'll just a warning for those people who are online as well too. There are some pictures of surgery, so just be aware about that as well too. Thank you, Brendan.
So I suppose I'll just run very quickly through my interaction with Jess. So I had a phone consult in May 2020, and it looked like Jess had regular cycles, which were painful. Had been using the Billings method. So we started Jess on some letrozole, just to see if that would give her ovulation a little bit of a nudge. So then had another consult, and had an ultrasound suggesting an endometrioma on the left ovary. So at that point, I thought it would be a good idea to have another look. And this time with the robot, we have access to robotic surgery for endometriosis, and I think that's makes a big difference for endometriosis in the setting of infertility, because the vision's so superior to normal laparoscopy, and the ability to resect endometriosis in tricky places is better. So we carried out the surgery in July 2021 at St Andrews in Toowoomba. So in terms of my findings, there was the other thing I do Novi catheter dye studies. So that's where we put a catheter at the beginning of the fallopian tube and can flush the tube under vision from above. But they were fine. But the ovaries and fallopian tubes were adherent to the pelvic sidewall, and there was a large right-sided endometrioma. There was extensive endometriosis on the uterovesical peritoneum, both uterosacrals, both pararectal regions, in the pouch of Douglas, overlying the rectum, both ovarian foci, both fallopian tubes. So it was quite a decent resection. In fact, it was probably the most decent resection I've ever done, maybe, at that point in time. So this is endometriosis here. This is on the right uterosacral ligament. There's also endometriosis here. This is overlying the rectum. And you can tell it's endometriosis because there's this sort of stellate appearance as it causes scarring. And when there's scarring, it sort of contracts the tissues. This is me actually suturing the right ovary back. So that's the needle from the suture. You can see the robotic instruments sort of holding things. So that was after we'd pulled out a large endometrioma on that ovary. You can also see on this is an after shot, after the endometriosis has been resected. This is where it's been resected from the right uterosacral. And I don't know if you remember back to this initial shot, you see it looks fairly small, the area of endometriosis, but after I've resected it, it's actually quite a large area. And when you're doing surgery, you can actually feel the endometriosis sometimes more than you can see it. So I've resected the whole area of endometriosis there, and also here. I've also resected the endometriosis that was over the rectum. I've used cold cut to resect that endometriosis because I am so close to the rectum. I don't want to cause a diathermy injury. But in order for hemostasis, I've sutured the peritoneum over the rectum back together. That's something you can't really do with a normal laparoscope. You can, but you have at least 14 sleepless nights afterwards because there'll be a bowel injury and it can take 2 weeks after a resection for a bowel injury to declare itself, which is one of the scary parts of endometriosis surgery. But I actually wasn't worried because firstly I'd used cold cut and secondly we sutured it. So I wasn't actually worried that there was a bowel injury. This shows, this is at the end of the surgery, and you can see more areas where we've cut it out. And this is co-seal, which is an adhesion barrier. So I'm spraying all of the operative surfaces with co-seal, which it's a barrier that takes about 2 weeks to dissolve or become reabsorbed. And the idea of it is to prevent adhesions. It's most important around ovaries. So we've done a resection of an endometrioma on this ovary. We've sutured it up and then we spray co-seal on it. The reason being that ovaries don't have a peritoneal lining and they'll be much more likely to form adhesions. And this shows, possibly can't see it, but you can see how everything's got that sort of a film over it of the co-seal, but we're also filling up the pelvis with another adhesion barrier called adept, and that causes everything to float. These are the histology results. So when I said it was a decent resection, I don't have many where there are 20 specimens. So you can see lots and lots of endometriosis. Yeah, so as mentioned, 16 days after the procedure, when I thought we'd be off the hook and you wouldn't have to worry about something happening, poor old Jess had a sudden onset of pain and was found to have a significant hematoma. So I suspected she had a bleed either from a cyst accident, which is where you get a bleed from a normal ovulation, or else there was a secondary infection. And certainly patients who have tonsillectomies can get a secondary bleed 2 weeks after the procedure, where the bed of the tonsils gets infected. And perhaps the same things happened in Jess's case 2 weeks after the procedure. The bed where everything was healing decided to get infected. So the colorectal team took her to theatre because they obviously were worried about a bowel injury, but they couldn't find one, which was good, and they couldn't find any active side of bleeding. But they did place 2 drains, which I suspect would have been quite uncomfortable for 5 days, and just made a slow recovery after this. Yeah, so, but yeah, that's sort of a bit of a snapshot of severe endometriosis and its management. But, and as you can see, it can sometimes not be without hiccups as well. Thanks.
Thank you, Dr. Miller. So just wrapping up, Jess and Paul, you've been through this whole journey. You've come a long way. Now that the journey's over in that regard, if you could do things all over again, how would you do it differently? And what advice would you give for other couples who may be facing fertility issues?
Okay, so our journey over. Well, we've got no regrets, we'll first of all say. But I suppose the first thing is I'd find this guy 10 years earlier. I'd also question medical advice given to me. Obviously, from early on, it was probably hard not being diagnosed earlier, but being put on the pill from such, so early, I wouldn't touch the pill if I had my time again. And it's no accident how we've been created as men and women, and it's important to know our bodies and especially our fertility side of things. So, learning billings, I wish I'd known it earlier, and I think it's something all girls should be taught at an early age.
Even boys too, I'd say, Jess. As a teacher, teenage boys would be very good for them. Finding the right specialist, and we've been so blessed to have Dr. Mary and Dr. Brendan. Also Patsy in there as well, all her guidance initially.
So our advice, obviously NFP, get onto it, find these two, look up Dr. Mary Walsh and Dr. Brendan Miller.
It's already been spoken about a few times this morning, I think, but just looking at health overall, holistic approach. So whilst we know that Dr. Brendan's surgery was no doubt the main factor for us being able to conceive, we think there was an element of stress in there, and day-to-day stress, maybe losing our jobs had some sort of an impact too. If you're a person of faith, trusting in God, so God's ways are not our ways, and he has a purpose in our lives, and I think during those difficult times that brought a lot of peace as well for us. So I guess we came to the understanding that maybe we weren't called to be parents, and whilst that's difficult, I think when you've got that belief in God, it certainly helps.
And we prayed a lot to Our Lady of Lourdes. She's interceded a lot for us. St. Joseph, and of course St. Jared Magella, the patron saint of mothers, sorry.
Journeying together, so the 6 years that were married before Luke's arrival, I think we just grew closer and grew in love and got to know each other better, and that's made us better parents too. It certainly opened opportunities for us in other ways. We studied for 5 weeks in Jerusalem together, and just those amazing experiences that we had along the way, enjoying the journey.
Yeah, and whilst we like to be in control, God actually is, and he has a plan. And it turns out that God's plan was much better than we could ever have imagined. So thanks to you guys. Thank you.
Thank you. Please join with me in thanking our panelists. So we've heard about the comprehensive and cooperative nature of restorative reproductive medicine. Thank you once again to everyone. And as we're wrapping up, we'd like to present a token of our appreciation to our panelists. Thank you, and we'll conclude the public forum there.
My name is Dr. Gabriel James. I'm an obstetrician and gynaecologist based in Brisbane, Australia, and I'm the current chair of the board of directors of the Australasian Institute for Restorative Reproductive Medicine. We're meeting here today for our National Fertility Conference in Melbourne. We've just heard the wonderful story of a couple that shared their fertility journey and how our members were able to assist them in conceiving after many years of infertility. The Australasian Institute for Restorative Reproductive Medicine is the peak body dedicated to holistic restoration of health and fertility for women and couples experiencing health issues, including infertility, but also ranging across many, many disorders such as PCOS, pain, mental health, and related disorders. We have members across Australia and New Zealand that are dedicated to supporting people through fertility education and medical treatments. We are very keen to reach out to anyone and support anyone that would like to get in touch with us. There is a website. The website is www.airrm.org.au. There you'll find a directory of members that are potentially able to support you. On the website, you'll also find more information about how our general approach to supporting these health issues and ways in which we can achieve this and the people that you can reach out to. I think it's very important for those people watching this through Shalom media to know that most of our members are of a Christian faith, and this means that we can really support you in your health journey with a complete view of the human person as God sees us. And I think that's really, really a key part of how we like to approach supporting you in your health journey. So thank you for watching, and would love to be available to support those couples that may want to reach out to us.